Greetings of the day. I am Dhanashree Warang, working in the Department Hospital and Research Center, Mumbai. Today, I am presenting a case report on the use of PGT-M to avoid deafness in the future child through proper genetic counseling. Heterozygous variants in the SCN5 gene on chromosome 3p21 leads to atrial fibrillation, familial 10 Brugada syndrome, cardiomyopathy, heart block, and long QT syndrome. These genetic disorders are inherited in autosomal dominant manner. Autosomal recessive deafness is caused by homozygous or compound heterozygous variants in the GJB2 gene. The non-consanguineously married couple who approached our clinic with history of 2 miscarriages, both were natural conceptions and one IUI failure. The husband also had a history of cardiological issues on the maternal side of his family. He was diagnosed with ventricular bigamy and arrhythmogenic right ventricular cardiomyopathy. He also had an ICD. The husband's brother died at the age of 22 years due to cardiac issues. There was no family history of deafness. Following tests were advised to the couple. Couple karyotyping, whole exome of the couple, fish test for DiGeorge syndrome in the husband. Based on the whole exome reports, pre-PGT workup was carried out for the SCN5 gene variant in the husband and GJB2 gene variants in the couple. The couple underwent 2 IVF-ICSI cycles where 10 blastocyst embryos were biopsied and subjected to pre-implantation genetic testing for aneuploidies. PGTA followed by PGT-M for SCN5 gene variant on 5 of 10 euploid embryos and GJB2 variants on 4 of 5 embryos were carried out. The couple underwent 3 frozen embryo transfer cycles. Pregnancy test was done for confirmation. Results: the couple karyotype and the husband's fish for DiGeorge syndrome was normal. On whole exome sequencing, the husband was heterozygous for autosomal dominant gene SCN5, which is pathogenic, and carrier for GJB2 pathogenic variant. The wife was heterozygous for GJB2 VUS. On PGTA, 5 of 10 embryos were euploid. After PGTM, 4 of the 5 embryos were unaffected for the SCN5A pathogenic variant. PGTM for GJB2 variants was carried out, and of the 4 SCN5 unaffected embryos, 1 was compound heterozygous, 2 were heterozygous, and 1 was normal for GJB2 variant. The lady got pregnant in the third attempt using a GJB2 carrier embryo with singleton pregnancy, which is ongoing. The couple's whole exome was advised to check for any other common disorder along with any pathogenic variant for cardiomyopathy. Whole exome sequencing showed presence of GJB2 variants, 1 pathogenic and 1 VUS, positive of deafness in autosomal recessive manner. The classification of variant of unknown significance may change in future to pathogenic, hence PGTM was advised. Without the whole exome sequencing of the wife and PGTM for variant of unknown significance, there was a high risk of having a future child with deafness. PGTA helped to select euploid embryo for successful implantation. This showed the importance of experienced genetic counseling and targeted genetic testing. Thank you.